damos comienzo al simposio SARC-INTUCAI, que sería el último. Vamos a comenzar con el doctor Chris Weibe, de la Universidad de Manitoba, Canadá, del Internal Medicine Department. Bienvenido, welcome, and thank you.
Gracias. Muchas gracias por la invitación. Quiero hablar mi presentación en español, pero no puedo. I only know about that many words in Spanish, maybe a few more, but not enough to give this presentation. But I do thank you for the opportunity to be here. It's a pleasure. And I will start, and I have no disclosures. And what I want to talk about, and was introduced earlier today, is precision medicine. The definition that I'm going to use is that this is medical care designed to optimize efficiency or therapeutic benefit for a particular group of patients, especially using genetic or molecular profiling. And as you heard earlier today, this is not a new idea. In fact, when I was a medical resident 15 years ago, oncology was already practicing this type of medicine, as you may know. At that time, if you were a breast cancer patient, you would have had testing for estrogen receptor sensitive tumors, you would have had BRCA1 genetic testing, and this would give you an idea of what type of treatment you might respond to and how you or your family should be monitored. However, this has not occurred at the same rate in transplantation. Nevertheless, we have an area that is really ripe for this type of advancement. We know that the two most common causes of graft loss in transplantation are death with function, which is usually from cardiac, infection, or malignant causes. And the second large category is actually immune-mediated injury, with chronic antibody-mediated rejection as the most common cause. What's interesting is that if you think about how our immunosuppression affects these two causes, they actually have the opposite effect. For example, if we were to give more immunosuppression, we know that this can cause cardiac toxicity, it can cause increased infection and increased malignancy. On the other hand, if we give less immunosuppression, we are certain to get more immune-mediated injury. So this puts us in a difficult position of trying to predict the precise amount of immunosuppression a patient may need without overdoing it. Now, unfortunately, if we look at the literature and ask the question, is this happening already? The answer is definitely no. Here is two studies that were done in the United States in the last few years, and both studies tried to analyze what was causing the heterogeneity in the types of immunosuppression that were being selected. In both cases, what they found for maintenance immunosuppression or induction immunosuppression is that statistically, very little of the variation in practice could be predicted by any patient-related risk factor. In fact, it was less than 6% for maintenance immunosuppression, and it was only 10 to 30% for induction immunosuppression. And just as surprisingly, the major cause of the variation was actually found to be the center effect, which is another way of saying where you had your transplant done. That means that if you had the same person get a transplant at two different centers, they were likely to be treated differently based on where they were entirely. So this is obviously not precision medicine. This is the opposite of precision medicine. This isn't even really empiric medicine where everybody is just treated the same. This is more of a biased approach to medicine. And before we're too hard on the physician, since I am a physician, we have to ask, why is this the case? And I'm going to argue that one of the reasons is that our current methods of alloimmune risk assessment are actually inadequate to help us refine our standard of care. And what are those methods? Well, if you think about the alloimmune risk at the time of transplant, there's basically two categories. There's what I call immune memory. This means you've been exposed, or the recipient has been exposed to the donor HLA in the past. And we can learn about immune memory from well-known correlates like sensitization history. Has the patient had a pregnancy or a transfusion or a transplant? And of course, these days we have very sensitive DSA screening that can tell us about donor-specific antibodies. Also, in the bottom, I've put memory B and T cell assays because we know in the literature these have been reported and they're in development, but I put them in gray because they are currently not prime time, they're not available to most of us. And I've also put PRA, or panel reactive antibody, in gray because actually this has been a weak correlate of immune outcomes for some people. But the reality is that multiple papers have now shown that if you comprehensively HLA type across all the loci, including HLA-C and including HLA-DR and DQ and DP, and then you rule out donor-specific antibodies, that there's actually no correlation between PRA and long-term graft survival for third-party HLA. Nevertheless, the point I try to make is that currently in 2019, we actually do a very good job of detecting immunologic memory in most patients, and it's largely because of our sensitive DSA screening assays. And that means that we can avoid immune memory in most patients. In Canada, we avoid memory in probably 90 to 95% of the transplants that we do. But that still leaves the other 90% of patients that have some sort of a risk for primary, or sometimes called de novo, alloimmune injury. And the risk factors on this side are also actually quite well known. There are things like younger recipient age, which we know correlates with a more robust or stronger immune system. HLA mismatch, which I'll talk a lot about. Immunosuppression adequacy, and at the bottom I put ethnicity again in gray because I actually don't think it's that helpful. We know that it has been reported, but in my opinion, ethnicity is confounded by different rates of HLA mismatch. It's also confounded by different rates of drug metabolism and even drug availability due to socioeconomic status differences, especially in the US. And lastly, we live in a global society where different ethnicities are intermarrying and there's genetic admixture occurring. And this means that self-reported ethnicity is actually becoming less and less precise all the time. So I don't think that's going to help us in our precision medicine approach. I'll also point out that really only two of these risk factors are available at the time of transplant, and that is the age of the recipient and the HLA mismatch. Now, post-transplant, if we're trying to detect that a primary alloimmune injury is occurring, we have a few different methods we can do that. One is de novo DSA development. I'm going to talk a bit more about that, and a further speaker is going to talk about that in a little while. And I'm going to define what I mean by that on the next slide. Allograft dysfunction is another thing that we can monitor, but most of us know that this actually occurs late. Multiple protocol biopsy studies have shown that you can have inflammation in a graft for many months or even years before dysfunction occurs. Of course, biopsies and histologic results are the gold standard for injury, but this is an invasive test that's also quite expensive, so it's not practical to do this on a regular basis. There are many biomarkers that are in investigation that I won't go through, other than to say that there's some promising ones, but there's currently none that are approved. Now, why might de novo DSA be a good correlate of a primary alloimmune response? Well, I've already mentioned the assay is highly sensitive. In fact, some would say it's too sensitive. We pick up antibodies that we don't even know what to do with. It's also widely available. It has a quick turnaround time. It's non-invasive. It's less costly than biopsies. It's semi-quantitative in nature, and most importantly, de novo DSA correlates with hard outcomes like antibody-mediated rejection and all-cause graft loss. And the cartoon at the bottom is meant to remind me to say that when we measure a newly detected antibody in the serum, we are not just measuring B-cell alloreactivity, because naive B-cells require T-cell help to actually become activated and switch to a plasma cell that secretes antibodies. Therefore, when we measure a de novo DSA, we're actually measuring both B and T-cell autoimmunity. Now, as many of you know, the vast majority of de novo DSA actually develop against the class 2 antigens, and so most of my research has focused on these, particularly HLA-DR and HLA-DQ de novo DSA. And as the figure at the bottom suggests, these are also one of the reasons we focused on these is they tend to be the most correlated with graft loss. So the question that I was asked to address here, and I'm going to go into more detail, is about precision matching and HLA matching. And the first question is, can HLA antigen mismatch move us towards precision medicine? And the answer to this question, I think, is no. And the reason is this word antigen. And what is an antigen? And because we're using translation, I want to be very specific that when I'm talking about the HLA antigen, I'm talking about the whole molecule, the way that we've been talking about HLA for many decades. Now, most of you have seen papers like these that show for every increase in the HLA mismatch, there's a corresponding increase in the hazard ratio of graft loss. And as you can see here, these are large population-based studies using registry data. For example, the study on the right had almost 190,000 patients. And the important thing to recognize here is that because this is population data, small differences can be highly statistically significant. So for example, on that figure on the right, each dot there on the graph represents 10 to 20,000 patients. That means that confidence intervals are going to be very tight and very small, and we can show a difference. That does not mean, however, that we can take those results and apply them in our clinic to individual patients and expect to see a difference. And I'll show you why in a few slides. One of the things that we have spent a lot of time looking at is this idea of de novo DSA development post-transplant. And I'm going to show you a few of these types of Kaplan-Meier survival curves. The top curve is showing HLA-DR de novo DSA development post-transplant, and I'm correlating that with the different HLA-DR antigen mismatches. And the same thing is on the bottom, but for HLA-DQ. What you'll notice here is that, of course, a zero mismatch correlates with low risk. But it doesn't seem to matter whether you're a 1DR mismatch or a 2DR mismatch. The risk of developing an antibody was completely overlapping, and that was also true for DQ. And this is despite having about 700 patients in this analysis. So if you can't show a difference with 700 patients statistically, how meaningful is it going to be when you apply it to clinic? And the second question is, why? Why is this the case? Or another way of saying that is, why is HLA antigen mismatch so imprecise that we would need tens of thousands of patients to show a difference? The answer to this is actually now understood. To start, you are all probably aware that there are many thousands of different HLA alleles. In fact, over 18,000 the last time I updated this slide. And the reason that we know that is because they've all been genetically sequenced. And since they're genetically sequenced, we also know what their amino acid sequence is of each of those proteins. And that's what I'm showing you on the bottom of this slide. If you haven't seen this kind of data before, what you see in that top row of letters next to what says HLA-DQ7 is those are all the amino acids in this example. I'm just showing you a portion of the molecule that's near the top of this HLA molecule. And underneath that, you see dashed lines wherever the amino acids are identical, or you see another letter put in there for each polymorphic amino acids. And the point of this graph is to show you that some common HLA-DQ molecules, let's say the top three there, HLA-DQ7, 8, and 9, are all almost identical. But the very bottom row, which is HLA-DQ5, is actually quite different. In fact, 11 out of the 40 amino acids within that red box have been changed or substituted. But if you think about how we treat this today in transplant, if you had a donor become available tonight who was a DQ7, and you had a DQ8, a DQ9, and a DQ5 recipient on your list, which one would you choose? Currently, we would consider each of those examples a one antigen mismatch, and we wouldn't take into account how similar or different those molecules are. But there's actually no reason to believe that the immune system feels the same way. In fact, there's certainly more non-self tissue in the bottom row. So So how could we apply this? Well, we know that when an antibody binds to an antigen, that epitope to paratope interface is driven by amino acids. And it's actually these complementary determining regions on the antibody that interact with small clusters of amino acids on the epitope, as you can see in that top figure. Now, René Duquesnoy developed a situation to account for this, which he called the HLA matchmaker approach. And that is, if you could identify on an HLA molecule where these polymorphisms occur, you could then ask the question, what other amino acids are nearby? And by nearby, he used a 3-angstrom radius because this roughly correlates with the binding surface area of one of those complementary determining regions on an antibody. He called this small cluster an eplet. And if you think about it, for each polymorphic amino acid, you can define its corresponding eplet. And if you start to do that, you can quickly generate a long list of eplets that will allow you to then compare any two molecules and ask how similar or how different are they. Of course, an eplet and an epitope are not the same. As you can see, the area in green actually represents the binding surface area of an entire epitope, whereas the eplet is just one functional unit of the full epitope. Now, if we start to compare molecules, what this will allow us to do is change the question. Right now, what we say is, do the two molecules match, yes or no? But what we want to do is ask, how well do they match on a quantitative scale? So if we do this in a large number of patients, this is what the raw data looks like. This is a cohort from our own center of 664 recipients. Each dot here represents one recipient and their mismatch with the donor. This is actually probably the most important slide in the whole talk. If you can understand this, the rest of the talk will make sense. On the y-axis here, you see the eplet mismatch, and on the x-axis, you see the conventional mismatch that we've all been using for many decades, either 1 or 2 for DR and 1 or 2 for DQ. I've just hidden all the zeros because there'll be 0 for both. Now, if you take a conventional mismatch of 1, what you'll notice is that there's a huge variation in the eplet mismatch there. And if you think about this, this actually explains why antigen mismatch would be so imprecise. And would also explain why you would need tens of thousands of patients to show a statistical difference in HLA matching. If you think about this analysis, if I just took these patients and instead of 600 did 60,000, what would you see? You would see that the confidence intervals would gradually get smaller until there would be a meaningful difference between a 1 and a 2 mismatch. The problem is, that's not where we actually live and practice medicine. What we do on a daily basis is we do this. We see recipient A at 9 in the morning, and we have to figure out what their risk is, and then at 9:30, we might see recipient B. And for many years, we've been trying to understand the immunologic risk of recipient A based on their conventional mismatch of 1, thinking that they might be lower risk than recipient B. But we could have actually had it backwards. And so this is a problem. If we want to practice precision medicine, the first thing we need is actually a precise risk factor that we can rely on. So let's look at how this new approach might actually correlate with outcomes. If we look at de novo donor-specific antibody-free survival again, this is the exact same analysis with the exact same patients as I showed you before. The only difference is now I'm using this eplet mismatch to stratify the patients instead of the antigen mismatch. So again, you see the DR mismatch on the left. I'm sorry that there's some mess up between the Mac and the PC here, but on the left you see that a 0 mismatch is of course still 0 risk. But underneath that, whereas before I could not separate the red and the blue line based on the antigen match, now using a eplet mismatch cutoff of 11 in this case, you can see that I can very nicely and in a highly statistically significant way stratify the patients into a high risk and a low risk group. Keep in mind that the number here is exactly the same. We've been showing this data like this since about 2013, although I'm referencing this paper because it's a bigger cohort that we recently published. And in fact, some others have followed this path and tried to look at their own data. And this is some data from a transplant group in Australia, actually, looking at lung transplant and actually showing something very similar. They looked at chronic lung allograft dysfunction and showed that by looking at the complete eplet mismatch across all loci, or just looking at the class 2 loci, that they could also stratify their patients in a highly significant way. Because of the time constraints, I'm not going to show you a lot of other data, but there is data from the chronic from chronic allograft nephropathy, as well as pancreatic transplants, and some data in cardiac transplant, but most of it, to be honest, is of poor quality, small studies and cohort analysis. We did do some work in an independent cohort with a group in the US in Minneapolis. And this study was interesting because this group had already studied this group of patients using what's called electronic pill bottles that would accurately and objectively monitor the adherence of the patients to their immunosuppression. And we said, well, that's really an important risk factor. We know that. Why don't we also do their eplet mismatch and see how these two risk factors work together? And what we found was not surprising, that if patients have both a poor eplet mismatch and they're poor at taking their medications, they are the ones who are the highest risk of both rejection and graft loss. But also, what's interesting is that if you had a poor mismatch, but you were excellent at taking your medications, you were actually protected. And similarly, if you were lousy at taking your medications, but you had a really good match with your donor, you were also protected. So this got us thinking, well, maybe we should look at this in more detail. So that's what we did. We went back to our own cohort, and we took a group of patients that were all treated with tacrolimus, Cellcept, and prednisone. It was a group of about 600 patients, and we downloaded and kind of put together every tacrolimus level that had ever been checked on any of these patients. It was well over 50,000 tacrolimus levels, and it allowed us in a very granular way to start looking at how well the immunosuppression was correlating with what was happening to the patients. What I'm showing you here is just the high-risk patients. In red are the patients who made antibodies, and what you see here is that the patients who were most frequently below target for their immunosuppression were the ones who developed the antibody. That's probably no surprise to anyone. But what was interesting is if we brought in the low-risk patients to the analysis, we could see that they were also having just as many tacrolimus levels that were below target, but they never developed the antibodies. So it wasn't actually the immunosuppression levels that were protecting them, it was their better mismatch that seemed to protect them. And although this analysis was done with the tacrolimus level there of 5 nanograms per ml, if you have a chance to look at the paper, we actually examined different targets for tacrolimus. And one of the arguments I make is that we don't actually know what the right target is for maintenance tacrolimus beyond the first couple of years. Another interesting thing that I'll just show you from this paper is that we also looked at patients who made the antibody and what was their drug levels throughout the time course of their transplant. So for this analysis, I excluded all of the levels in the first year because in the first year we're gradually kind of tapering down our target levels. And then I just looked at levels from 1 year forward to whenever they developed the antibody, because we're regularly monitoring for the antibodies, we know roughly when that is. And then I compared the 6 months before the antibody developed to all of the rest of the levels, whether it had been 4 years of levels or 2 years of levels. And what you see here in the blue is that most of the patients who developed antibodies actually had adequate levels for a long time. But right before the antibody developed, their levels were statistically significantly lower. And it didn't matter whether this occurred at 6 years post-transplant or 3 years post-transplant or even 8 years post-transplant. That was always the case, and it was statistically significant in every analysis. So this does suggest that immunosuppression adequacy is super important. It's not just about the match. I'm going to take a brief side note here just to mention that HLA-eplet mismatch is not the only way to compare how well two molecules are matched. There are other methods. I'm happy to talk about those other methods in more detail, but one of the other methods is a method that the second author in this paper, Vasilis Kosmoliaptis in the Cambridge of the UK, developed, and it's just simply enumerating how many amino acids are mismatched, or he had a second layer of this where he would actually take the amino acid side chains and he would ask the question, what are their properties? Are they charged or uncharged? Are they hydrophobic or hydrophilic? And he would use those to come up with a score, which he called the electrostatic mismatch. The bottom line is we compared all of these methods in this paper, and we found that they were all highly, highly correlated, which was no surprise since they all start with the same basic genetic information and the same basic amino acid differences. If you're interested, we also looked at multivariate models, and if you like statistics, we compared the multivariate models with the so-called AIC score, or Kiki Information Criteria score. If you're familiar with this, lower score is better when it comes to this scoring system, and it appeared that the eplet mismatch was at least as good or maybe better than these other methods, but they were all quite similar. I also know from becoming friends with Vasilis that he's working on a new program that might be an improvement on this one. Now, that data has all been published actually, and it's been out for a few years, so I'm sure you've all read it and memorized it. I'm now going to present something that's brand new, and that is something we're calling the single molecule mismatch approach. This is actually in EPUB right now in the American Journal of Transplantation, but it should be in print soon. And the idea here is to take the eplet mismatch approach and try to make it even more precise. So to review, what we currently do is this traditional whole molecule mismatch approach, where we take the two molecules from the donor, let's say these are two HLA-DQ molecules, and we say, are they the same, yes or no? And in this case, both were different, so I called this a two antigen mismatch. And we've tried to correlate that with some sort of outcome. The eplet mismatch approach that I've been talking about so far, we did the same thing. We took both molecules, we looked at them in detail and counted up the eplets, and then we added those together and came up with a score, which in this case was 12, and then we correlated that number with an outcome. The single molecule approach is to look at each molecule individually and ask, what is the risk for that molecule of developing an antibody? Because for antibodies at least, we can do this because we know which antibodies come from which molecules in most cases. And so, especially for patients who have only one match, it doesn't really make sense to be combining the scores into one score. So we examined this statistically, and what we found was that the traditional approach had an AUC score for predicting antibodies of only about 0.54, which is not much better than just flipping a coin, for reasons that we've already talked about. The eplet mismatch score had a huge jump in the AUC to 0.72, whereas the single molecule approach actually brings that up to 0.84. The problem that some of you might already be thinking about is now you have individual scores for every molecule. This is a bit cumbersome, and you might say, well, how can we bring all of these scores back to the individual patient and say, you know, what is their risk? So to do that, we take the scoring system and then we develop cutoffs that seem to be important, and then we ask the question, do any of the molecules exceed those cutoffs? So of course you can do that with a receiver operating characteristic curve type approach, and that's just what I'm showing you here. And you can see that the cutoff for HLA-DR was around 7, for DQ 9. You don't have to memorize these numbers, but just giving them to you. Now, if you then ask the question, do any of the molecules cross that approach, or those cutoffs, sorry, this is what you see. So first of all, the y-axis here has changed, and the reason is that now I'm doing one analysis for all patients. So I'm looking at, did they make an HLA-DR antibody or an HLA-DQ antibody? Before I was doing those two things in separate analysis. Now we're taking the whole group and trying to figure out what their risk is. Now, as before, the top line is patients who have a zero mismatch in green. Right underneath that, though, is patients who don't have a zero mismatch, but when we looked at all of their molecules, every molecule was below those cutoffs that I just mentioned. And if you add up these two groups, they actually make up about a quarter, or 25%, of the entire cohort. So we said, well, clearly both of those are low risk, so we're going to combine those into one group and call that low risk. And then we decided, because there's still 75% of the patients left, let's see if we can split that group into two more risk groups. So we repeated the ROC analysis and came up with another cutoff to help split up the rest of the patients. So now we have three groups. We have a low risk group, we have an intermediate risk group, and we have a high risk group. And we can apply that to our immunologic outcomes and see how it behaves. What we saw is if you look at de novo DSA development, it nicely stratifies the patients into high, intermediate, and low risk groups, and each group is highly statistically significantly different. That was no surprise because we developed this scoring system based on the antibodies. Then we applied this system to some of the other outcomes. And we found for antibody-mediated rejection-free survival, it was also a very good predictor. That was also probably no surprise because about 2/3 of patients will have evidence of antibody-mediated rejection when you first detect an antibody. But it also correlated very nicely with T-cell mediated rejection. So this is BAMP 1A or greater T-cell mediated rejection in the first year. And in multivariate models, it also correlated with graft loss. And in fact, for each of these outcomes, the alloimmune risk was both a univariate and multivariate predictor of these outcomes. And to even say that, it sounds, well, how can one risk factor at the time of transplant predict all of those outcomes in a multivariate model? It sounds too good to be true, but the reality is that all transplant immune-mediated injury is driven by differences between the donor and the recipient. And maybe for the first time ever, we have a very precise way of quantifying those differences. Now, one of the things I like to point out is that this is not some expensive new assay that you need new equipment in your lab to calculate. In fact, probably every one of your labs has the ability to do this. You just need the HLA typing and you need the software, which is free to download. It's actually now being incorporated right into the Fusion software offered by One Lambda. It has been, I think, for about the past 6 to 8 months. And if you don't have Fusion, you can download it from the internet and just input the typing, and in 5 minutes it'll spit out the number of epilet mismatches. So that makes it quite fast, inexpensive, and widely available. Of course, it has a good predictive ability for de novo DSA and some of the other immunologic outcomes. And importantly, it's available right from day one. In fact, in our own center, we provide this information to the physicians for all new transplants on day 0 so that they can use it to select their induction immunosuppression. So with my last few slides, I'm just going to summarize what I think are a few of the approaches that we could use this type of information for. The obvious is allocation. I often don't even talk about this in the United States because I know the last time they changed their allocation algorithm, it took 8 years to make a change, and so nobody wants to even hear about it. But the reality is it could help us improve long-term outcomes by improving the risk. It also is important for pediatric patients who are likely going to receive more than one transplant and to reduce their risk of sensitization. Of course, it could also be used to enrich clinical trials. We know in transplant there's been very few drugs approved in the last 10 to 15 years. Part of the reason for that is because it's a very difficult area to study. And the FDA has been asking for some time for predictive and prognostic biomarkers to be developed so that trials could be enriched and could be potentially smaller and in shorter duration. Of course, we're here to talk about precision medicine and how this could help us here. As I mentioned at the beginning, if we understand both the risk of alloimmune memory and primary alloimmunity, we could potentially personalize both our immunosuppression and our monitoring strategy. Last year, we wrote an opinion piece about this in AJT, if you want to find the figures here. I'm just going to summarize in 2 more figures a little bit more detail about how we might do this. And that is, if you have a donor-specific memory risk, of course, we think and we know actually that these patients are high risk, and we might know that through their DSA testing at the time of transplant, or sensitization history, or perhaps one of these fancier, newer ELISpot assays. If we have high risk, of course, those patients are going to need more aggressive immunosuppression. And this isn't to give any details on that, but just some general points. Of course, as I mentioned before, the vast majority of patients are not going to meet that criteria. Most patients we transplant are in the bottom group. And I mentioned that molecular mismatch and recipient age are the two risk factors that we have here that we could maybe start to select different categories of risk and treat them differently. Perhaps low-risk patients don't need induction immunosuppression. In our own center, we use induction in about 30% of our patients. Perhaps we don't need the same targets of tacrolimus for all of our patients. Of course, this is just as applicable to monitoring. Right now, we have great monitoring tools such as de novo DSA monitoring, but they're expensive and they're time-consuming. And if you have a large cohort of patients, this can utilize a lot of resources. But I just mentioned that in a large cohort, 25% of the patients are low risk, and low risk was defined as a 1% incidence of de novo DSA at 10 years. So those patients probably don't need to be monitored frequently. In fact, you could probably use your resources more wisely by monitoring the other high-risk patients who are more likely to have an event. And that's true for de novo DSA monitoring, but it might also be true for pathology, doing protocol biopsies or doing urine screening with chemokines, whatever system you want to use to monitor. So I thank you very much for your attention. I want to particularly say thank you to two of my mentors, Peter Nickerson and David Rush. So far, everyone I've met here knows these two people. So that tells me that they are very important people, and as many of you know, David Rush is from Argentina, so that makes them especially important. So thank you very much for your attention. I'll be happy to answer questions at the end.